welcome to the second part of the 12th masterclass of Jaipur surgical tutorial. For those of you who could not join yesterday and who are watching today's video for the first time, Jaipur surgical tutorial is an online education portal which we started about 3.5 years ago at the Mahatma Gandhi Medical College and Hospital in Jaipur. This is being managed by my colleague, Dr. Anand Nagar, who's an associate professor of HPV surgery and liver transplant at my institution here in Jaipur. And the technical support is provided by the team of Dr. Avinash Tank at the Dwarika Clinic in Ahmedabad. In the Jaipur surgical tutorial, we conduct a weekly session every Saturday, 9 to 10 India time, where students present cases and sometimes they present operative procedures, which are then discussed and moderated by faculty. All the proceedings of the Jaipur surgical tutorial are video recorded, and all these videos have been uploaded at the YouTube channel of Gastro University. So if you put Gastro University or Jaipur surgical tutorial on YouTube, you will get to these videos. In addition to these Saturday morning sessions, a few months ago, we started Friday afternoon sessions. But we are kind of reconsidering them because the live attendance in those sessions dropped significantly. So we may kind of end them, but all those videos are also here on the YouTube channel. And then last year, we started these master classes, which are held once in a month, last Thursday and Friday of the month, 7 to 9 p.m. So 2 hours into 2 days, where a single theme is discussed. We've covered several topics like safe cholecystectomy, liver donor liver transplant, acute and chronic pancreatitis, care of a critically ill patient, abdominal tuberculosis, intraoperative bleeding. The theme of the 12th masterclass is abdominal trauma. We covered some general aspects and mainly liver trauma yesterday. And I'm happy to inform that till just now, we are reaching almost 200 views of the yesterday's video on the YouTube channel of Gastro University. And for today's second part of the masterclass, I would like to welcome my senior colleague, Dr. R.A. Sastry, who's at the KIMS in Hyderabad. And I would request Dr. Sastry to moderate this session after I have introduced the speakers. So for today, the theme is pancreatic trauma. And to set the ball rolling, I would request Dr. who's first? I think Kishore is first, Dr. GSB Kishore, who is at Fortis in Jaipur, and he will be talking to us about grading of pancreatic injury. But before Kishore starts, over to you, Dr. for opening comments, and then Kishore can start.
Good evening, everybody. Nice to be back to these Jaipur Surgical Society seminars. And I must compliment first Dr. Vinay Kapoor for this great initiative. And it has become so successful. And the Jaipur Surgical Society too. And welcome to all the panel members. So the symposium was started yesterday with abdominal trauma. The basic principles of abdominal trauma were covered yesterday, and the blunt liver injuries and their management. These are covered. And today, we are scheduled to cover the pancreatic injuries, the principles, and then the management, and also penetrating injuries. These are the three topics scheduled for today. Traumatic injuries of pancreas are notorious because they are difficult to diagnose because of non-specific clinical signs, confounding multi-organ injuries, which most of the time accompany the pancreatic injuries, and the subtle imaging findings, which may not always lead to a clear diagnosis and the localization of pancreatic injury. So a high index of suspicion, as well as knowledge of the anatomy, the mechanism of injury, the pre-injury status, as emphasized yesterday. These are important in suspecting pancreatic trauma. Later, we grade the injuries, and then they use the available imaging modalities judiciously, the CT, MRCP, ERCP, for an accurate diagnosis. Imaging, of course, has a vital role. The management, we do have certain guidelines, but they are of a high range. They are ranging from simple conservative management to a drainage, simple drainage, a debridement and drainage, or the local resections, or complicated resections, depending on the grade and the hemodynamic instability and the severity of the injury. We'll probably have an exposure to all these principles of pancreatic trauma management. So I'll reserve my comments for later. Let us start with the grading of pancreatic injuries. Dr. GSB Kishore from Fortis, Bangalore. Dr. Kishore, floor is yours.
Good evening, everybody. Thank you, sir. And thank you, Professor Kapoor, for this invitation. I'm really happy to be part of this great teaching initiative. I'll just share my screen. Sir, is it visible?
Yes, it is.
So, like sir just said in his opening comments, pancreatic injury is actually quite rare. It constitutes only about 2% of abdominal trauma. But when it is present, it is always almost in about 60-65% of the cases accompanied by other organ injury. So it becomes very, very important for us to have an early as well as high quality CT scan to diagnose pancreatic injury. So this is, of course, as emphasized early, in a stable patient. The two most important determinants of outcome following a pancreatic injury are the time from injury to definitive diagnosis. So this should be preferably less than 24 hours, and status of the main pancreatic duct. So this has a lot of implication in management. Before we go on to the actual grading, let's look at some terminology in terms of type of injury, relationship to the superior mesenteric portal vein complex, and involvement of the main pancreatic duct. A laceration is a discrete linear or branching area of parenchymal tear. The contusion is defined as an indistinct area of parenchymal edema, whereas tissue loss is defined as non-viable geographic region of tissue destruction, which is characterized by loss of identifiable architecture or traumatic displacement from the pancreas. So these are the three basic types of injury that can be described on a scan. The other important thing is relationship to the SMPV. Injuries to the right of the SMPV are considered proximal. Those to the left are considered distal. So in a CT scan, typically head and uncinate process injuries are proximal injuries. Body and tail injuries are distal injuries. The third important determinant in terminology is the main pancreatic duct. So injuries superficial to the duct are superficial. Those involving the duct are deep injuries. Perhaps a more sensible terminology would be low grade and high grade. Low grade injuries not involving the pancreatic duct, and high grade injuries involving the pancreatic duct. The common grading system used is the American Association for the Study of Trauma, American Association for the Surgery of Trauma, AAST. So a grade 1 injury is a hematoma or a minor laceration, which is superficial and does not involve the duct. So it is a superficial injury. What one should remember is when a CT scan is done, it should always be a multi-phase CT scan, because if a single phase is done, areas of hypoenhancement may actually be missed out. Many times in trauma, CT scans are done as soon as the patient comes in arrives in emergency if he's stable. But we should remember that the injuries can evolve, and many a time a repeat CT or an MRCP can be done if the index of clinical suspicion is high. Also, we should remember that many times pancreatic injuries are subtle, and we should look out for the so-called secondary signs, and this may give a clue to pancreatic injuries. So this is a paper from AIMS which described the secondary signs. As GI surgeons or general surgeons or HPB surgeons, we often see acute pancreatitis more than trauma, but the findings are essentially similar. There will be fat stranding in the peripancreatic areas, peripancreatic fluid collections along the left anterior renal fascia or pararenal spaces. And yesterday, Dr. Yadav was mentioning, this is an important point again, extraperitoneal or intraperitoneal fluid without solid organ injury. This usually signifies a mesenteric tear or a bowel injury. But we should also remember two other things. One is, of course, a pancreatic injury with ductal disruption, or in pelvic fractures, a extraperitoneal bladder rupture or intraperitoneal bladder rupture, where the fluid can be either urine or pancreatic ascites. Of course, associated injuries are common, as we mentioned earlier. So these are secondary signs. There can be fluid which interdigitates between the splenic vein branches, or it goes anterior and posterior to the pararenal spaces along the pararenal fascia, around the adrenal. The same thing here, fluid in the lesser sac and fluid around the superior mesenteric artery. So these are all secondary signs that we should watch out for. A grade 2 injury is a major contusion or a major laceration, but without duct injury. Now, major means what? Now, the pancreas is conceptualized as a cylinder. So if more than half of the thickness of the pancreas is involved, if more than 50% is involved, invariably the duct will be involved. So then it qualifies for a grade 3 injury. So anything less than 50% involvement of the thickness becomes a grade 2 injury. A grade 3 injury is a distal transection, complete transection, or a deep parenchymal injury with involvement of the duct. So it is noteworthy that when the duct becomes involved, it becomes a grade 3 injury. So this is a CT scan showing a grade 3 pancreatic injury. Here we can see that almost the full thickness of the pancreas is involved, and there is hematoma around the pancreas in the lesser sac, in the Morrison's pouch. In the coronal section, we can see the same. Also, we can see the viable pancreas is enhancing here, whereas the non-viable pancreas is not enhancing, and there is some contrast extravasation as well. So probably there is a complete or a near total transection of the distal pancreas, qualifying it to be a grade 3 injury. So main pancreatic duct involvement is critical, but CT is not perfect in diagnosing this. There are some limitations. So whenever a main duct injury is suspected, careful review of the CT scan should be done in all three planes to see if the main pancreatic duct is involved. A grade 4 injury is a proximal transection or a deep parenchymal injury involving the ampulla or the intrapancreatic bile duct. So this is a grade 4 injury. Again, a CT scan, cross-section from cranial to caudal. We can see that there is a linear pancreatic laceration here, which is extending caudally and going down here. And there is associated duodenal hematoma or injury, and there is some fluid in the Morrison's pouch as well as in the pararenal space. So this becomes a grade 4 injury because it is a proximal injury. we should remember that whenever we see a duodenal injury, we should always look out for an ampullary and bile duct injury. So the highest grade is a grade 5 injury. A grade 5 injury is a massive disruption of the pancreatic or duodenal complex. This is a shattered pancreas. And this is associated with a high likelihood of duodenal injuries, almost always present, and vascular injury. So this is a CT scan where we cannot see any outline of the pancreas. It is completely replaced by blood. And also we see an area of active contrast extravasation signifying a vascular injury. It is brighter than the aorta. So vascular injury should be suspected in high-grade injuries. Now, vascular injuries are not actually a part of AAST reporting, but radiologists should be on high alert if they see this, and surgeons should be ready to do the necessary to stop the bleeding. Again, to emphasize, in higher grade injuries, associated organ injuries are the norm, and they frequently dictate management decisions. To summarize grading, grade 1 and grade 2 AAST injuries are minor injuries. They do not involve the duct. Grade 3 injuries are deeper injuries. They involve the duct. Grade 4 injuries are proximal. And grade 5 injuries, of course, are disruptions. Like we discussed yesterday for liver trauma, if there are 2 minor injuries, like if there are 2 grade 2 injuries in the pancreas, it can be upgraded and reported as a grade 3 injury. So up to grade 3, 1 grade can be upgraded depending on the injuries that are present. So there are some modifications which are being proposed for the grading system by AAST. It is proposed that grade 2 injuries be separated into A and B based on the relationship to the SMPV. And grade 5 injuries are described as disruption of the pancreatic or duodenal complex, but it should be properly and probably more descriptive details should be provided. A devitalizing non-reconstructible duodenal and ampullary injury with MPD transection is strictly a grade 5 injury. Also, grade 3 and grade 4 injuries, that is ductal transection distally or proximally, are again proposed to be subclassified based on the duct alignment, because this will have implications for ERP and stenting. And sometimes if patients have not had CT scans, intraoperative ultrasound can be used for grading, and this is can be done by trained people or HPB surgeons. But again, this is limited by availability of expertise and logistics in a trauma setting. The World Society of Emergency Surgery is a very, very similar classification system. It just clubs AAST 1 and 2 as grade 1, AAST 3, which is distal transection, as 2, and the proximal and head injuries as grade 3. What is noteworthy is that the grade 4 injuries are patients with hemodynamic instability irrespective of the grade of injury. This was again emphasized in the discussion yesterday in liver trauma. There's another classification. This is an old one in 1997 based on a retrospective study of about 20 odd patients. Essentially, they looked at injuries as involving the tail or head and whether it was deep or a complete transection. So again, this has management implication. It's a simplistic sort of classification of just of interest. There is also a ERP-based classification based on pancreatograms obtained at ERCP. So here again, class 2 and class 3 are partial injuries and complete injuries respectively, and they can be in the head or body or tail. So that can be described. So again, if there is a partial injury, probably ERC may help. If it's a complete injury, surgery. So this is based on a retrospective data of 35 patients of people who underwent ERP, and they found that this classification had management implications. So that was the purpose of the classification. Lastly, this group from South Africa, they have the largest experience of abdominal trauma and probably in the world. And they have come up with a multivariate analysis and scoring system they had a derivation cohort and a validation cohort, and they found that 5 factors, which is age more than 55 years, shock at admission, presence of major vascular injury, more associated injuries, and higher grade, which we just saw, all these 5 factors, they have been given weightage, and they have found that they could subcategorize patients as low risk, medium risk, and high risk for mortality. And they found that this has a bearing on patient management and prognostication. So thank you very much for a patient hearing. So just to summarize, a high quality CT is absolutely required to diagnose and grade pancreatic injuries. Grade 3 and above means duct is involved. Grade 4 injuries are proximal injuries. And grade 5 disruption, of course, is a shattered pancreas. Thank you.
Thank you, Kishore. Yeah, that was a good account of the grading of pancreatic injuries, which was like any other grading, is not a perfect grading. We need to add things, and there are a few things which are missed in grading. What I wanted to emphasize, apart from grading, before you come to grading, the mechanism of injury, particularly in pancreas, is also important in raising a suspicion of pancreatic injury. An unrestrained driver, hitting the steering wheel and the pancreas getting caught between the steering wheel and the spine, that is a classical injury. And in your examination also, it's important that you look for any external injuries which may give you a suspicion of pancreatic injury, like the contusion or the seat belt, and in the areas where you would strongly suspect a pancreatic injury. They ultimately, in you grade them definitely for comparison purposes and to develop protocols. It is important to have a good grading. But in practice, what ultimately matters is, one, the hemodynamic stability or instability which the patient comes, because multiple associated injuries are quite common with pancreas, and pancreas injury gets masked in these. The injuries, as you assess on imaging, basically, is it a clean cut? Is there a laceration? Is there a contusion and some devitalized portion of the pancreas, which means there is some tissue loss, and then ductal. See, these are the things which you would concentrate on in the pancreas, apart from whether it is to the right or left of SMV, because that would again is important to decide on the type of management. These are the few things I thought I should add. Rest of them probably we'll take up later. Shall we go to the second presentation?
Yeah, Kishore, I have two questions. So type 5 injury is always at the head and the duodenal complex. You cannot have a type 5 injury in the body or distal pancreas?
Yes, sir. Type 5 injury is described always in the head. So it is in the head, involves.
So the most severe injury in the body and tail can be only type
grade 3. Grade 3, sir.
And the other is it possible that if it is a blunt injury, that there is an intraparenchymal, say, contusion or hematoma, which has disrupted the duct, but the capsule of the pancreas is intact, which means that there is ductal disruption, but there is no parenchymal disruption?
Yes, I suppose it is possible, sir. In decelerating injuries or a heavy blow to the epigastrium. But eventually, I think if the duct is leaking, it may form a pseudocyst or something and present later. But yes, the mechanism is perfectly plausible, and it would still constitute a grade 3 or a grade 4 injury, depending on the location of the pancreas.
And because because ductal integrity or injury is a very important factor in this classification, What, in your opinion or according to guidelines, is the investigation of choice? Is it CT, or once you have a suspicion of pancreatic injury on CT, should always an MRCP be done? And what is the role and place of a diagnostic ERCP?
So CT scan and MRI have similar sensitivities and pickup rates for ductal injuries in with current imaging. There was a study from AIMS also recently, which looked at utility of CT versus MRCP in pancreatic trauma. So they found that with good MDCT reconstructions, we can predict ductal injuries. But of course, an MRCP will definitely add value if the CT findings are equivocal and the clinical suspicion for ductal injury is high. Role for ERCP is as a diagnostic modality, I think, is limited in modern day practice. But if a therapy is planned and pancreatic duct stenting is planned, then a pancreatogram is probably the gold standard for diagnosing pancreatic injuries, and especially in grade 3 injuries, maybe grade 4, without too much displacement of the duct, it may be a possibility, especially in the proximal injuries rather than injuries in the tail.
If I may add a little here, the closed ductal injury, as Dr. Vinay was referring to, is rather uncommon. The pancreas, to take the brunt, it involves a lot of trauma. And that kind of trauma is very unlikely that it would not rupture the superficial pancreas, and it would only rupture the pancreatic duct. In any case, that kind of thing would not be presenting in the immediate post-trauma situation. It might show a little later, as Dr. Kishore is saying, as a pseudocyst or any such. I also want to ask Dr. Kishore, what is the role of amylase and lipase in the diagnosis of pancreatic trauma? I understand, of course, I know it is as a diagnostic investigation, probably it does not have a role to start with. But then when you have a serious suspicion of pancreatic injury, serial amylase and lipase values, say done 6-hourly, may help in confirming your suspicion. What do you feel?
I agree, sir. That's what the literature says, exactly what you said. In a patient who is stable and otherwise okay, amylase lipase value, say, performed like 48 hours or later and monitored serially, may raise the suspicion of pancreatic injury and be a trigger for an imaging. Although there are multiple factors where amylase lipase can go up with trauma, it can could be multiple factors. But I think it has a sensitivity in the range of about 40 to 50%. That's what the literature says. That
would be a trigger for probably a second CT.
Yes.
A first CT may miss a pancreatic injury. And if you have the signs of this kind, like amylase or lipase high, it may be an indication for second CT. Yeah. Shall we go on to the next presentation, Dr. Vinay?
Yeah, we have a minute. So in case any other faculty member wants to make a quick comment.
Yeah, Sitaram. We have TD Yadav. Yeah, TD? Sitaram, please.
Yes, sir. Good evening.
Yeah,
that's what Dr. Kishore was talking about. Sometimes there is a hematoma in the ruptured pancreas, and because of that hematoma, even if after good reconstruction, it's sometimes very difficult to recognize the ductal injury even on the table. And that sometimes the distal pancreatectomy is basically done based on the CT finding and the parenchymal rupture. But usually duct is intact. So it's a rare, sometimes very difficult. And here, maybe if patient comes little bit late, MRCP might be the one of the good way of recognizing the ductal disruption. If there is no other pressing indication to go ahead for surgery, then probably this is one area where one can add MRCP for the management of the patient, whether go conservative or go for a surgical management.
Dr.
Yeah,
Sitaram?
Madhur wants to say something.
Prafum, sir. I just want to add a few things. First, to Dr. Sastri's suggestion about getting amylase and lipase. So not only it helps in when you evaluate serially for the diagnosis, but it is also very helpful to have a baseline amylase lipase so that later when you have to remove the drain, the abdominal drain, and it shows that it is less than 1/3 of what it was before, you can safely remove the drain. The literature says that. And we've had talk about MRCPs, ERCPs and all. One practical problem with these patients is that these patients usually are patients of polytrauma. Most of the times they're intubated. And all this paraphernalia they have around are not MRCP, MRI compatible. So many a times in practical situations, this is a problem. So that in those cases, CECT does its job in a very efficient way. But if the patient is stable, we have all the ferromagnetic compliance of the things, and we have to diagnose, then of course MRCP and ERCP have a role.
Okay, I think we'll move on. So I would like to introduce Dr. Madhur Uniyal, who is at AIIMS Rishikesh. I'm happy to welcome him for the first time in Jaipur Surgical Tutorial. And actually, his name has been recommended by Dr. Puneet Dhar. I had earlier requested Puneet, but he was gracious enough to suggest that Madhur could cover this topic. Welcome, Madhur, to Jaipur Surgical Tutorial, and we hope to see you in more and more of our sessions in future also. So Madhur is going to talk to us about the principles of management of pancreatic. Over to you.
Thank you, sir. So, sir, am I visible?
Yes,
Yeah,
yes.
very.
Please. Please start.
So good evening all. I'm Dr. Madhur, like sir said, and I'll be talking about pancreatic trauma management principles. So I have nothing to disclose. So I want to begin by saying that the signs and symptoms of pancreatic trauma are always, they depend upon associated injuries, which are quite very much. So 19% of them have associated liver injuries, 16% of them have stomach injuries, 11% splenic injuries, 8% colonic injuries, 8% duodenal injuries, and other injuries as well. So basically, they will the effect of all these injuries will overlap. So describing signs and symptoms and presentation will be a part of primary and secondary assessment of these patients. So whenever we talk about primary assessment, the ATLS way, the first thing that comes into our mind is MIST, which is the pre-injury information format. It stands for mechanism, injuries, signs and symptoms, and treatment. So what mechanism do these injuries usually have? So you can see the clothesline injury when somebody is driving a motorcycle and there's a clothesline which he fails to see. It hits him in the upper part of the chest. Probably the bumper of a car hits a person in the upper part of his abdomen. Somebody strikes the patient, or seatbelt injury like Dr. Sastry told. So all these injuries, they involve a linear force in the upper part of the abdomen. The literature says that blunt injuries are much more commonly associated with pancreatic injuries than penetrating injuries. And 80% of these blunt injuries, road traffic injuries, are the culprit. What usually happens is there is a strong linear force in the upper part of the chest. It crushes the pancreas against the spinal cord. And then there is compression against the spine, and usually there is contusion or laceration of the pancreas, and this usually occurs at the neck or proximal body region. This patient, of course, we have to follow the ATLS protocol when they reach our ED. So first what we do is we look at the airway, we see whether the airway is patent or not. If the GCS of the patient is not that low, not less than 8, so that his tongue might fall back. If there is no regurgitation, no foreign body in the mouth, no saliva, we clear the airway and stabilize the cervical spine. Then we look at the breathing and ventilation part of the patient, whether the chest is rising equally on both the sides, whether there is less air entry, showing there might be a pneumothorax or a hemothorax, whether there are chest compression tests, which is the allotment of one hemithorax followed by the other to look for any bony crepitus or surgical emphysema. And of course, the saturation, which we see on pulse oximeter. Then the circulation part comes in the part of the management where we put 2 IV bore cannulas, draw samples for blood cross and cross matching, look at the patient's heart rate, whether it is indicative of any tachycardia, blood pressure and all, whether they're indicative of any hemodynamic instability, and pelvic compression test, whether it is associated or not, and FAST examination. FAST is focused assessment by sonography for trauma, which has come up, which has become now a stethoscope in the primary and secondary survey, and which looks for fluid in the peritoneal cavity and tells us whether the patient might be bleeding because of trauma. All these things, if there are any problems, they manage simultaneously and do not follow in the scope of this presentation. We look for the disability, where we see GCS, where we appreciate whether there is an anisocoria or not, or whether lateralizing sign, whether the patient is able to move one half of the body more than the other because of some central nervous system injuries. And then of course, we examine the patient from head to toe and prevent the hypothermia. The main cause, the main purpose of primary survey is to save life or limb. So if we manage all these things in this manner, we might be able to save the patient. But you must realize, or you must have appreciated, but in all these times, pancreatic injury diagnosis has not come into picture, neither the suspicion of it. Because pancreatic trauma, they seldom lead to immediate loss of life. So when do they come into picture? The secondary survey. Secondary survey is head-to-toe examination of the patient and everything else we do after primary survey to help that patient. So secondary survey in head-to-toe examination of the patient might reveal an injury, a bruise, or a contusion in the zone 1 of the hemithorax, which houses pancreas, duodenum, and the large vessels. This is a patient who shows a typical bruise in the upper part of the abdomen in the zone 1. This might, after doing the primary and secondary survey, this gives us a hint of what diagnostic modality we should go for. And of course, also, it might raise a suspicion of pancreatic injury and aortic injury or large vessel injuries in these regions. So what radiology might be helpful in trauma emergency department? Ultrasound. Well, we all know that ultrasounds are usually, they fail to appreciate a retroperitoneal organ like pancreas, and most of the times bowel gas is one of the reasons. CECT, contrast enhanced computed tomography. It is fast. It can assess the patient in a fraction of a second. It is a very good tool to even assess other injuries in the body, be it soft tissue, solid organ, or bony injuries. And it can be easily done in an ED patient. So, though the pancreatic duct injury, which we have based our talk, that it is one of the primary indications for intervention, it might not be picked very well by CCT, but it picks everything along with a high index of suspicion for pancreatic trauma. MRCP, like the discussion with them, if there's a high index of suspicion, then MRCP is a choice. ERCP is also a choice. It is very accurate. The specificity is the highest of everything and else, but it's an invasive procedure, only to be done in times of when the patient is absolutely stable. There are no other associated injuries. Sometimes in grade 3 pancreatic injuries with one wall intact, ERCP can also be therapeutic. So this is a typical radiological plate of a CT patient with pancreatic trauma. This is the almost the location where it usually occurs, at the junction of the neck and the body. And there is a hypoechoic shadow, which is the break in the continuity of the parenchyma of the pancreas. And how do we know that it's a CT scan, ductal injury? How do we know? So it is taken that if more than 50% of thickness of pancreas is crossed by this hypoechoic line, then we consider that the MPD violation has been done. Of course, there are other signs as well, like peripancreatic collection, fat stranding, swelling, and all those things. But this is the primary thing which we look for while examining a CT of the patient. CT of the patient, unfortunately, is also not very sensitive in first 12 hours. So small injuries can be missed in first 12 hours. And these injuries might later on present while evaluation of the trauma of the patient as increasing abdominal pain, which you cannot account for. It can also present by increasing abdominal tenderness, persistent vomiting, or inability to tolerate oral light. Everything is fine. Patient is tachycardic, tachypneic, is vomiting frequently, not able to tolerate oral diet, unexplained hypotension, leukocytosis, and increasing might look for. Explained just before. So I will just try to use it for the management plans. So these American Association of Society for Trauma guidelines are radiological guidelines. They are not intraoperative guidelines. They are radiological guidelines. So I'll just go through brief. The first is just a hematoma. Second is injury, which is there in the pancreas. On which I want to
Madhur, we seem to be losing your voice in between, I think, your internet connection. But anyway, please carry on.
mesenteric vessels, and fifth is shattered head of the pancreas with associated duodenal injuries or complex injuries. So with this thing, I want to say that the operative indication starts from 3, or any intervention starts from 3. So violation of the
I think this internet
Voice.
connection is not stable. We'll wait for him to reconnect.
Am I audible, sir?
Yes,
Yes.
but we lost your slides.
I'll submit them
Please
again.
share them again. But in the meantime, Kishore, the other classifications, is there some evidence to support or to say that they may be more practical and more useful than the AAST?
Sir, is my slide visible, sir?
Yes, now we can see. Yes, please.
All right.
We'll take that question later. Please go ahead.
Sure, sir. So, basically, 3 where the intervention starts, and 4 and 5 definitely we have to do something about it. So I'm very sorry, sir. My presentation has flunked. I think my PowerPoint is also not visible, but I'll talk about it. So what do we do when we have the decision for intervention is there? If there are no associated injuries, then the patient can be taken to and if a wall is intact, then ERCP can be a good modality where so now what do we do when there is a what type of incision? If the patient has to be operated, there's surgery, then what incision do we give? is of great help here. So what do we do then? Then so by holding the gastrocolic ligament, we hold the colon in our right hand, we pick it up, the gastrocolic ligament is
Your
there.
slides, Madhur, your slides are not changing. We are still at the radiology.
I know, sir. Allow me, sir.
Go to full screen mode.
Just give me a moment, sir.
Yes, please.
I'm sorry, sir. There's some problem with the slides, but I'd talk with this if it's okay, and we can have a discussion later.
Okay.
So what happens is, sir, the patient is taken to your OR, a large vertical midline incision is given, a Thompson retractor is of great help. The colon is lifted, the transverse colon, and the gastrocolic ligament is there in front of the surgeon. Protecting the both the epiploics, it can be opened by a cautery or by energy source, and then there is an entry to the lesser sac. Here I must say that there is a sign which has been described in literature, Mishra's sign, which has been given by my faculty in AIIMS Delhi only. Mishra's signs say that if there is a hematoma or a laceration in the lesser sac, there's likely to be a pancreatic injury. So it is a highly sensitive sign. So whenever, before even opening up the lesser sac, we have to inspect the lesser curvature of the stomach and the lesser sac there. If there is a hematoma or if there's a laceration, it is an indicative of a pancreatic trauma inside. So after opening up the gastrocolic ligament, usually we see signs of saponification or we see some collection of a pancreatic fluid. So following that, we easily reach the surface of the pancreas. We create a space there, and then we usually see a hematoma there, and on debridement of that hematoma, we reach surface of the pancreas. Of course, we have to open up the entire capsule to appreciate the anterior surface of the pancreas. If it is grade 3, which is distal to the superior mesenteric vessels, which is in most of the cases, the condition is there, then a distal pancreatectomy would suffice. Gently lifting up the pancreas of the splenic artery and splenic vein and proceeding distally, we are able to do distal pancreatectomy. And if you're able to save the vein and the artery, then most of the times we are able to preserve the spleen. The usual trick of the trade is either if you don't have an energy source like ligashore or harmonic, we can use 100 clips. There are multiple caterpillar vessels which feed the pancreas from the artery and the vein, and we can ligate them very well by an endoclip or a 100 clip. Or if we have an energy source, nowadays the ligashore is very user-friendly. It has also come articulating, and it is very helpful in dissecting the pancreas of the pancreatic bed. The proximal stump then has to be taken a great look at. It can be cauterized. Cauterizing it sometimes cicatrize the pancreatic duct, which in most of the cases is very difficult to appreciate while operating a pancreatic trauma. So after doing that, the fold of omentum is taken and it is kept over the pancreatic stump, and later on with the hope that it will seal off the pancreatic injury and there is no pancreatic fistula which develops later on. So this is the basic step which is there. Of course, it is proximal. What to do then if it is proximal to superior mesenteric vessels? Initially, the literature said that almost around 80% of the pancreas can be sacrificed without any signs of pancreatic insufficiency. And now the newer studies have revealed that even 90% can be safely excised. Only 10% of remaining pancreas are sufficient enough not to cause pancreatic insufficiency. So even in grade 4 injuries, which are just near the superior mesenteric vessels on the right side, on the proximal side, and if you think that 10% of pancreas is remaining and it can be saved, so it should be done, because the other option requires many anastomosis, and of most of the times these patients are on inotropes, which are a major cause of failure for any difficult anastomosis. The grade 5 is usually ends up into traumatic Whipples, which we call. There's pancreatic with the gastrojejunostomy, and sometimes dunking is done. So pancreaticojejunostomy is an option here. So what post-op things after operating, after dissecting the pancreas out, and in most of the cases when it is the distal pancreatectomy which we do, we place usually 3 drains. We place 2 drains at the bed and 1 drain in pelvis. These 2 drains can be used to irrigate also later on, because of course some leaking is there after the pancreas, which is mostly appreciated by patients developing tachycardia more than baseline. And so the wash can be given, and it usually solves the problem. And a drain is kept. Like Professor Sastry initially said, the importance of amylase and lipase, it is very important in the post-operative period, especially when we have to make a decision to remove the drain. We check the serum amylase and lipase, and if they are 1/3 of the baseline, we think that it is the time to remove the drain. So what post-operative complications, what other complications can occur which are associated with the pancreatic trauma? The other complications associated with pancreatic trauma is a pancreatic fistula, which is the most dreaded complication. Here, I just want to add that pancreatic fistula, somatostatin inhibitors, they don't cause any health. They just manage the fistula. But if you see the evidence, there is no evidence that suggests that they have any action on healing of the fistula. Pancreatic pseudocyst in around 20% of the cases is there. And sometimes in unoperated patients for a long time, it can be seen. And cystogastroscopy is one of the options nowadays, done very well by endoscopic methods. And laparoscopic too. So these are the basic things. One thing we have to look after the surgery for pancreatic trauma is feeding. Enteral feeding, unlike the large NPO status in the earlier days, has come into vogue. It has to be started early. Post-pyloric feeding is preferred. So at the time of surgery, it is usually it helps a lot to negotiate the Ryle's tube distal to the pylorus, or otherwise a feeding jejunostomy is also an option. Spine has to be inspected very well whenever you are expecting a pancreatic trauma. We have always to look twice at the spine, that because more than 18% of pancreatic trauma have spinal injuries associated with them. So these patients usually require a very good care in post-operative care in ICU, where they have to be looked for all the things. Especially the chest has to be, they have high tendency of developing pleural effusions. They have and pancreatic fistula and all those things. So they have to be meticulously seen in the post-operative care in ICU. And if surgery is done well, and if they are done in earlier they have been done, the better the outcomes are. And but nowadays, if there's a grade 3 injuries and surgical expertise is there, even post-operative day 10 are being operated with a good outcome. So thank you, and I'll be open for any questions. I'll be happy to address them.
Madhur, yeah, Dr. Sastry, please.
Yeah, thank you, Madhur. Yeah, the principles of management of pancreatic injury you have clearly shown. But then my question is, if you see the recent literature, like all solid visceral injuries, conservatism is recommended in majority of pancreatic injury cases also. So we have, later probably I can show our own publication of the 84 cases or 92 cases of pancreatic injury, and 34 of them grade 3 and grade 4, and only 8 were operated early. And rest of them, some of them were operated late, and we did not find any difference in the complications or the morbidity or mortality. even patients who have developed pancreatic fistula with a pancreatic ductal rupture did not do that badly, in the sense that we did not lose them. Yes, morbidity did increase with a pancreatic fistula, but that could be managed. Or a post-trauma pseudocyst or any of these could be managed later once the acute phase is crossed over. This seems to be the trend. What is your opinion on that?
Sir.
Conservatism in grade 3 and grade 4 injuries.
So conservatism is increasing all the solid organs, and that is more because of the emergence of intervention radiology. So most of the spleens which we used to take out earlier can be managed very well by angioembolizations, and so is this for liver, which is much more common than spleen, which we realized later on after the coming of CT that liver is much more forgiving and it was being managed. Unfortunately, intervention radiology has not much role, but endoscopy sure has a good role in ductal injuries. So in isolated ductal injuries or isolated pancreatic injuries, if the patient does not have comorbidities and one side of the wall is intact, and if there's a good endoscopist, it is possible to do interpapillary stenting and go for a thing. I'm very happy to hear about your experience, sir, but still the protocol and still the evidence which we have studied and which I've studied a few days ago and from AIIMS Delhi also was pointing out towards operative management of grade 3. So I'm really intrigued by a study. I would like to definitely go for it, read about it, but it should be seen, sir, definitely with increasing options. The only thing it is there, sir, that if operated in time, they have wonderful outcomes. But if we do delays, thinking about managing them conservatively, then later on, sometimes even the operations are very difficult to, it becomes very difficult to perform surgeries on delayed pancreatic traumas.
So at surgery, is it possible, is it an option that if suppose the pancreas is divided into two pieces and you don't want to sacrifice a major part of the distal pancreas, but is it an option that you place a stent across operatively, one limb into the proximal, one into the distal, and provide good drainage? Yes, there will be pancreatic fistula, but as Dr. Sastry said, then it becomes a controlled external pancreatic fistula, which you can handle later by whatever methods you want. So is that an option?
Sir, theoretically, it sounds like an option, but since the alternative is so simple that you do a distal spleen preserving distal pancreatectomy and you close the proximal stump, that would be a risk which we would be taking. The alternative is very simple, and usually the outcomes are very good.
Yeah, but I'm not convinced by the evidence. I will have to go into it in detail because see, when we do pancreatoduodenectomy, we are removing only about 40 to 50 or maybe maximum 60%, and still there is a significant long-term risk of exocrine and endocrine insufficiency. So why is it that in trauma, you said that just 10% is good enough?
Sir, so this is not my saying, this is an evidence which has been generating. And if you talk about our experience, so last month we operated about 5 of them, and 2 distal pancreatectomies were proximal. So we had a very good outcome with them, but of course, on the evidence pyramid, it's not even 6. But the literature points out that about 90% of the pancreas can be removed. The current literature says that it can be removed without any thing for insufficiency.
And
so
these studies have long-term follow-up, 2 years, 5 years, 10 years.
The evidence for 80% has been since long time, sir. The 90% we'll have to look at it, that how much long follow-up is there.
One more thing we have to look into here is we are talking of a normal pancreas, not a diseased pancreas.
True.
It's I think it's criminal to sacrifice 90% of pancreas, hoping that nothing would happen. It is not fair. As Dr. Vinay was suggesting, we also did. In fact, my own resident, who is a professor now, he has a series of 8 continuous cases of grade 3 and 4 injuries where ductal disruption was there. I think 4 or 5 of them were clean cut, but 3 of them had contusion in addition, where he debrided, brought the 2 stumps together, and with a nasal feeding tube or a celastic tube, which the neurosurgeons use for their shunts, stented it across, and in fact did a ductal anastomosis. And he has a 4 or 5 year post repair follow-up showing very good pancreatic duct and the preservation of pancreatic parenchyma. So what I want to emphasize is a conservatism in terms of not only the surgery, but conserve the pancreatic parenchyma too. And it is well evidenced that even when you resect, what we do is if we resect also, if it is a proximal resection, we don't do the definitive anastomosis at that stage. We do a stage procedure. We must remember that these patients have a lot of associated injuries, and they are physiologically disturbed, and doing a full-fledged Whipple's is problematic, and it is fraught with a lot of complications. It is not only that, the diagnosing the pancreatic injury on table is not that as simple as we've been saying. Like say, ductal disruption is so very well seen, obvious, and then you take a call on whether to do a proximal or distal pancreatectomy. It is not that simple. Things are confused, partly necros. See, it is not as though we operate immediately. There are hematomas there. It is sometimes very difficult to even diagnose a ductal disruption without, doing too much of a debridement there. And it is also important to emphasize here the complicated dissections in a traumatized retroperitoneum around the pancreas. We can do a lot of collateral injury. I think that needs to be avoided. But I think it's an important lesson we must give to the junior colleagues who are too aggressive about pancreatic injury management. I think it is something which we have learned over these 30 years. And we operate, one, when there is a hemodynamic instability. When you have a definite ductal rupture signs, we definitely first try a ARCP and ductal stenting. And if it is not possible, yes, we do operate. But again, a conservative surgery in terms of simple drainage, simple ductal drainage, or resectional drainage, depending on the situation which you are seeing there, but not do complicated repair procedures there. This is one thing which I thought I wanted to emphasize, and we have evidence now. All the recent grade 4, grade 5 injuries that are reported in the literature, there is the incidence of conservatism is much more evident than immediate surgery, unless there is a contusion of the pancreas, there is ductal rupture, and hemodynamic instability. These are the 3 things which we always look into before you decide.
Madhur,
Yes,
in a
sir.
grade 5 injury, if we have to do a resection, as you said, then is exteriorization an option? And if exteriorization, obviously the pancreatic duct, what about the biliary and the gastric or duodenal?
So in which cases? I beg your pardon?
Grade 5 injury, we
Grade
have to
5
do
injury.
resection, pancreatic or duodenectomy. So instead of doing the anastomosis in a polytraumatized, hemodynamically unstable patient, is exteriorization at that stage and reconstruction later?
So, well, that is the primary principle of damage control surgery in a traumatic patients. So, if the patient is on ionotropes, is acidotic, any of the radical procedures are deferred. So, exteriorization is definitely an option. But there has been an option also that while operating these patients, so if the patient is stable and we have to do an anastomosis, for example, a hepatocystectomy is required. Now, cystocystectomy is usually an option as well. So it is coming up in literature recently. that cysto, because usually hepatocystectomy we do for common bile duct injuries in other occasions. But in trauma, and in common bile duct injuries, usually the bladder is gone already, gallbladder is not there. But in these cases, even cystogenostomy is an option, which is much more easier for younger people, people with less experience to do. But to answer your question, definitely externalization should be considered if the patient is unstable due to one reason or the other.
Yeah, so just to clarify, when Dr. Madhur says cystogenostomy, he means a cholecystogenostomy.
Cholecystogenosis.
I think we can move on. And next, I would like to invite Dr. Santhosh Irrinki, who's in the Department of Surgery at the Postgraduate Institute of Medical Education and Research. And I specifically requested him to cover the topic of penetrating injury, because that is something where the differentiation between low and high velocity and conservatism versus surgery. So it's a little bit unrelated, but I thought it's important from students as well as practicing surgeons' point of view. So Santhosh, please.
Thank you very much, sir, for your kind introduction. At the outset, I would like to thank Professor V.K. Kapoor and Dr. T.D. Yadav for giving me this opportunity to talk on penetrating abdominal trauma, which is a topic which is very close to my heart. So to start with, we all know that penetrating injuries are not so common, especially when they are seen in terms of a larger perspective of all the trauma that presents to a given trauma apex center. This is supported by older evidence. However, when we go through evidences before 2000, abdominal trauma used to be constituted only around 3.8%, of which only 12% were penetrating injuries. But the scenario is fast changing, with increasing incidence of high velocity accidents and increasing industry associated impalement injuries and growing access to the firearms and increasing violence in the society. These penetrating injuries are only increasing, and they have almost reached up to the level of almost 11.6% in one of the recent studies from a South India based study. But this is only about the stab injuries. The other associated gunshot injuries, if they are considered, they are reaching almost up to 12 to 15% of all the trauma that is presenting to the trauma centers. Why is it important to know? They are easy to identify, and if they are managed at the right time, the morbidity and the mortality associated with these trauma can be significantly reduced, and hence reducing the length of stay and cost of treatment. These can range from a small stab injury, as small as the injury that is seen in this photograph, to as dramatic as these injuries, which can happen following bull gore injuries, or sometimes even with penetrating traumas that can happen in industrial impalements also, causing significant evisceration. Overall, if you see at the causes can be broadly divided into ballistic and non-ballistic injuries. Why is this differentiation important? Because ballistic injuries are generally associated with significant collateral damage throughout the path they pass, especially if it is a high velocity injury. For the non-ballistic injuries, they are generally low velocity, and they are not causing significant amount of damage in terms of number of organs involved. However, they still cause life-threatening injuries. Non-ballistic injuries include stab injuries or accidental penetration of sharp objects and bull gore injuries. The management of penetrating injury starts from the site of trauma, and it is just as any other trauma. There needs to be a rapid access to the patient by the pre-hospital care unit, and there should be an initial assessment of airway, breathing, and circulation at the site. There should be immediate stabilization of the neck, and the protocols of scoop and run in-transit stabilization all are followed even in penetrating abdominal traumas. However, there are certain specific things which I would like to highlight. If there is an ongoing bleed from a penetrating injury, that should be controlled at the site of wound by doing a local dressing and compression. If there is no significant spinal injury that is noted at the site of injury, then probably you can allow the patient to take a position of most comfort. Most commonly, we would advise the patient to have a supine position with hips flexed and knees flexed, so that the tension on the anterior abdominal wall is reduced, and hence the pain during the transit. If there is a significant evisceration, rinsing of eviscerated bowel is useful in clearing the gross contamination, and the exposed content should be covered with moist, sterile dressing, and this dressing should be kept moist until they reach to the hospital. do not force attempt to reduce any contents into the abdomen unless there is a very large defect and it is getting difficult for you to do the primary dressing. Most importantly, you should train your pre-hospital teams, especially in terms that death happens only because of the associated injuries. Hence, transit and stabilization during transit and the rate at which the patient is brought to the hospital is more important, because that will prevent irreversible damages that can happen because of delay in transit. Avoid hypothermia during transit, and there may be advantage in terms of reducing the overall risk of infective complications, especially in open wounds, if an early antibiotic is considered in such penetrating injuries. This is the position in which the patients are generally brought in the transit if there is no spinal injury. Again, I'm not going into the details of MIST, as Dr. Uniyal has already described. And once the patient reaches the hospital, obviously the initial assessment is just as any other trauma patient. Just because there is a dramatic injury on the abdomen, it doesn't mean that we should jump over and look at the abdomen first. Rather, the basics like primary survey with airway, breathing, circulation, followed by disability and exposure assessment should be performed with simultaneous resuscitation of the patient and assessment of basic vitals to look for any hemodynamic instability. Then we can do the secondary survey of the patient, which is a systematic and definitive examination from head to toe. There should be, if the patient is stable and if we have the possibility to attain a history, then only we should take additional information in terms of what is the mechanism of injury, whether it is a high or low velocity injury, if is it a stab or a firearm injury, number of wounds, and what is the entry and the exit wound, distance from the assailant, and amount of bleeding at the site of the incident. Most of the times we will not get this information. However, the bystanders or the police officials who generally get these patients to the hospital will have some information, and we can ask them, because that will help us in assessing the patient further. And the abdominal examination should always include not only the anterior abdominal wall, but once we rule out any other spinal injury, especially through the thoracolumbar region, then we can do a log roll maneuver by rolling over the patient and looking at the back for any posterior stab or perforating injuries. And it is important that at least 3 people should be present at the time of log roll maneuver, and 1 person should be stabilizing the neck during the log roll maneuver. And most importantly, if there is an impaled object or a penetrating object in the abdomen, that should not be removed in the emergency. Rather, that should be attempted only in the operating theater, because that may initiate a significant amount of bleeding and things might turn bad in the emergency situation. And sterile dressing should be performed once the penetrating wounds are examined. And routine trauma protocols in terms of prophylactic antibiotics and tetanus shock surgery should be completed. And generally, we have penetrating injuries presenting to us in 3 different scenarios broadly. One with hemodynamic instability, the patients who are hemodynamically stable at presentation, and the people who are referred to us when with a missed injury or after a delay from the time of the trauma. Coming to the initial set of patients where they present with significant hemodynamic instability. Generally, there are again 2 different sets of patients who present to us. When patients are brought to us in time, and if they are pulseless, then most of the times they are associated with significant major vascular injury underlying. In such a scenario, a rapid assessment for the chest injury should be done, so that would guide what type of surgical exploration has to be performed. If abdomen is the cause of the hemodynamic instability, then such patients may need immediate laparotomy, sometimes even within minutes. However, the outcome in such patients is significantly dismal, and that has to be explained to the family members even before taking up the patient for such emergency explorations by your assistant, not you. Hemodynamically instability needs immediate laparotomy, especially patients who present to us with hypotension. Those may be non-responders or transient responders after the initial resuscitation. Start with the initial fluid bolus, and such patients have to be initially stabilized, resuscitated, and reassessed, and we should avoid unnecessary investigations except for basic bedside adjuncts like chest X-ray or ultrasound fast, like Dr. Uniyal has very well elucidated in his presentation just for me. We should continue the resuscitation and then decide if the patient needs an immediate assessment. For all unstable patients, we should remember that damage control resuscitation is the most important. And it is actually the continuum of the care from the time of injury. The basic aim of damage control resuscitation is to minimize the time to physiological restoration by avoiding inappropriate interventions. And we always try to avoid the dark ages during damage control resuscitation, like hypothermia, acidosis, coagulopathy, and massive transmissions. In damage control resuscitation, there are three main components, that is permissive hypotension, hemostatic resuscitation, and hemorrhagic control. Once your initial resuscitation basically constitutes of permissive hypotension and hemostatic resuscitation with blood products, and if necessary, such patients with hemodynamic instability has to be taken up for an emergency damage control surgery. The damage control laparotomy consists of an immediate access to the abdomen, control of the bleeding, continue on-table resuscitation, and then reassess the status of the patient to decide what has to be done further. If the patient continues to be unstable, or if there is any evidence of persistent acidosis or coagulopathy, then such patients had to be shifted to continue further resuscitation into the ICU. And once the physiological homeostasis is achieved, such patients have to be taken up for a reassessment of surgery or a relook surgery at least 24 hours later, and then a definitive surgery can be performed on a 1 day later. And basic strategies during the damage control surgery include there should be a rapid midline laparotomy and evacuation of the blood with fourth quadrant packing, and then a wide retraction is provided. And we have to try identify the cause of the bleeding, and that has to be controlled first. If there is an ongoing contamination, that has to be tackled only after controlling the bleeding. We should do a complete inspection of all the hollow viscous organs and also the solid organ injuries, along with the diaphragm and retroperitoneal assessment. After achieving the control of the bleed, these patients, then we have to wait and allow the anesthetist to do the on-table resuscitation, and then probably we can reassess the status of the patient and then decide what has to be done further. If the patient continues to have the problems like hypothermia or persistent acidosis, then a temporary abdominal closure with or without the packing, depending upon the existing situation, has to be performed. If a packing or a temporary abdominal closure is done, then we should always not forget to document what is the indication of the damage control of the surgery, what are the intraoperative events and findings, and what are the conditions, what is the condition of the patient at the end of on-table resuscitation, and if packing is done, what are the total number of packs that are placed and what is that location. That has to be clearly documented. There are certain damage control strategies based upon the type of injury we encounter during damage control surgery, which include, if there is a bowel injury, a resection of the bowel injury with the closure of the proximal and distal ends, either by simple stapling or the closure with the suture can be performed. An immediate washout and drain placement can be performed. Should we do an anastomosis at damage control surgery? The evidence is controversial, but logically thinking, any procedure that is added during damage control procedure is only going to take more amount of time, and hence it doesn't make sense to do an anastomosis at that particular point of time. Rather, closure of the stumps and reassessing on the relook is going to be more logical option according to me. If there is significant bleeding from the liver, packing is the best option. The suture replacement has also been described in literature. However, that is not what we routinely perform. Rather, a good packing is good enough in order to maintain the hemostasis in such situation. If there is a retroperitoneal hematoma, that has to be explored for, and if there is any vascular injury, that should be immediately repaired. If the repair of vascular injuries are not feasible, then probably use of temporary shunts or ligating if it is a venous bleed, and using a balloon tamponade is also useful. And this balloon tamponade can be provided with simple things like Foley's catheter also, which would provide some time for the anesthetist to resuscitate and also give you time to reassess the injury if we can do the repair in the same sitting per se. Coming to the second set of patients who present to us in a hemodynamically stable patient. Obviously, the assessment again is the same. Initial resuscitation, primary and the secondary surveys has to be performed as per the trauma protocol and assess the site of penetrating injury. We should do a focused search for the signs of injuries, which should be location specific and injury specific, based upon where the penetrating injury is located in the abdominal wall. And we should make a clear roadmap for the assessment. If there are any obvious indications such as for emergency laparotomy like peritonitis or evisceration and impalement, then an emergency laparotomy should take a priority over a contrast enhanced CT, which is a common mistake that is that we come across our residents who try to do a CT even before doing the emergency laparotomy when indication is obvious. So in order to make a proper roadmap of assessment, we need to have a good comprehensive assessment, which includes clinical assessment, radiological assessment, and the blood workup. And clinical assessment, as we have discussed, it should include a detailed history and examination, and it should be performed only as a part of secondary survey like we have discussed. We should look for any signs of abdominal distension, signs of peritonitis, and we should do the wound assessment. That is, what is the location of the wound, what are the number of the wounds that are present, especially in the gunshots. These can be multiple, and including local wound exploration whenever it is warranted. Rectal examination is not mandatory even as per ATLS protocol in penetrating injuries because of its low sensitivity, and it only increases the time for assessment. Serial monitoring of the vitals and especially the outputs of the tubes. Like we should look for the outputs of nasogastric tubes and the Foley's catheter to look for if there is any ongoing bleed or what is the urine output that is seen. The basic radiological assessment includes an initial chest X-ray and FAST, which can be performed on the bedside. And once the patient is hemodynamically stable, and if the clinical situation warrants, then further contrast enhanced CT can be performed. And basic blood workup that we do should always include an arterial blood gas analysis with lactate, and hemogram should be performed to look for the hemoglobin status and the total leukocytic count. Blood group and cross matching as a part of trauma protocol, and RFT, renal function test and liver function test should be performed as a part of initial investigation. What is the role of amylase and lipase? It is controversial again. Some people, like there are some groups which strongly are proponents for sending amylase and lipase, especially in the initial stage, because these are the only soft cues that would allow us to understand that there might be an associated pancreatic injury. And this is true, especially if the traumatic injury is present in the upper part of the abdomen. However, we should always remember that amylase levels can be elevated even with all of these injuries, which are also common injuries in penetrating injuries. Coming to local wound exploration. Local wound explorations are only done in hemodynamically stable patients, especially if you want to assess for underlying peritoneal breach. These should be performed under strict aseptic conditions with universal precautions, and it should be done in the emergency department per se, under good local anesthesia. It is not just simple probing, rather we should try to assess the entire tract of the wound and see what is the end of the tract, and look if it is going beyond the posterior fascia of the abdominal wall. If it is so, then we consider that it is positive for the peritoneal breach. And if it is not going beyond the abdominal wall, then in hemodynamically stable patients, the chances that there might be associated intra-abdominal injuries are significantly low, and such patients can be considered for immediate discharge within few hours. However, in obese patients and when wounds are tangential, and especially in gunshot wounds, the role of local wound exploration is significantly limited. One more important thing is the abdomen is grossly divided into regions based upon the possibility for the type of injuries and the seriousness of the injuries that are possible, and what is the type of intervention that we may have to do in these patients. Grossly dividing, it is the anterior abdominal injuries, thoracoabdominal injuries, flank region injuries, and the posterior or the back injuries. How do you define anterior abdominal injuries? The injuries that are present between GP sternum and symphysis pubis, below the level of the costal margin, and between the two anterior axillary lines, that is the anterior abdominal region. whereas thoracoabdominal region is present between the fourth intercostal space or the nipple level to the lower part of the costal margin. Between the two anterior axillary lines, it is anterior thoracoabdominal region, and between the two posterior lines, it is the posterior thoracoabdominal region. The flank region is defined as the region between the lower part of the costal margin, the iliac crest, and the anterior axillary line and the posterior axillary line. Coming to the radiological assessment, like the initial assessment for all patients of trauma is chest X-ray, and chest X-ray is very important in assessing what is the extent of injury, even in penetrating injuries of abdominal walls. For example, if you are going, if you see this image where we had a patient who had presented with an anterior abdominal wall bullet injury, we can clearly see there is significant right-sided pleural effusion. We can see that the bullet pellets have been distributed both in the abdominal cavity and the thoracic cavity. Thus, the possibility of a diaphragmatic injury is also present. And the extent of bullet pellets that have been distributed will tell us that there are multiple cavities that are affected. So simple chest X-ray is showing that there are multiple cavities involved, that there might be a role of extended FAST where we would be assessing the right hemithorax in order to see what is the significant, if there is a significant amount of hemothorax, and then it prioritizes that chest is more important in a given patient, and an ICTD placement should take priority in such patients, and then further assessment of the abdominal cavity can be performed. If a CT is being performed in such patients, then it also tells us what are the areas that we need to look for and what are the injuries that we need to be looking for. Chest X-ray gives multiple information in terms of the mediastinal widening and deviation, presence of pneumothorax, hemothorax, or rib fracture. In terms of diaphragm, it tells us the level of the diaphragm, it tells us the congruity of the dome of the diaphragm, and also if there is a herniation of abdominal contents grossly. It can give us an information. And in gunshot wounds, it gives us a gross assessment of extent of damage. After chest X-ray, ultrasound FAST is the next most commonly performed investigation on the bedside. However, in hemodynamically stable patients, the routine trauma X-ray series can be performed only after confirming the initial stability of the patient if you suspect any peripheral injuries. And CT should be performed in such patients when warranted. We will go through the details of it in the later slide. What is the role of ultrasound FAST? FAST is nothing but focused assessment with sonography in trauma. Unfortunately, FAST is not as good as it is in blunt trauma abdomen with penetrating injuries. Why? Because FAST can only tell us if there is a hemoperitoneum, and if there is a hemoperitoneum, it cannot tell us if that patient needs a laparotomy or not. If FAST says that there is no hemoperitoneum, that doesn't mean that there is no intra-abdominal injury. So at the most, it can only rule in a hemoperitoneum, but cannot rule it out. But it has certain advantages in penetrating injury, where we can do a chest assessment in extended FAST, especially in thoracoabdominal injuries. And it is also sometimes useful in assessing the facial defects of the anterior abdominal wall in penetrating injuries. And in serial clinical assessment during selective non-operative management, an ultrasound FAST can be useful to see what is the extent of the fluid in comparison to the baseline assessment. Coming to the role of the CT in penetrating trauma, first of all, we should understand that this is done only in hemodynamically stable patients. It provides extensive information in terms of the depth of injury, the extent of injury, the type of injury, the base, and gives a better assessment of pelvic and retroperitoneal organs, and also gives us the severity of injury. Most importantly, it would help us select patients safely for non-operative management, especially if they are hemodynamically stable, and prevents unnecessary laparotomy with a sensitivity of around 94%. What are the protocols of contrast enhanced CT that are performed? First, it should be a thin slice CT. At least a 64 slice CT has to be used with multi-detectors. And IV contrast should always be given. Enteric contrast is not indicated in patients with abdominal trauma. Though it is controversial, it doesn't make it is time consuming, and it also increases the risk of aspiration in patients who are not conscious and oriented most of the times during the after the trauma. Rectal contrast is indicated only in patients when colorectal injuries are suspected, especially if it is a back and flank injuries. Generally, a triple phasic CT is performed, especially if you are suspecting a solid organ injury in the peritoneum, which can be using an arterial, portal venous, and the venous phases. And special protocols are used with delayed cut, especially if we are suspecting a ureteric injury or a bladder injury. But always remember that assess the patient before and after the CT scan, which is very important. Do not let the CT scan delay any pressing event that warrants immediate intervention. Always accompany the patient and try to look at the imaging yourself. Clearly mention the following on your requisition, which includes the mechanism of injury, the location of injury, whether it is a ballistic or a non-ballistic injury, and what are the suspected injuries according to your clinical assessment in a given patient. And always discuss the imaging with the radiologist, because your clinical inputs will always fetch better reports in trauma. And how do you assess what are the possible injuries in a given trauma? You need to know what are the organs that are occupying a given area. We all know that it is the abdomen is divided into 9 different areas, and each abdominal area has specific organs. And your suspicion should be area specific, especially it should start from the site of injury. For example, if the injury is present in the left hypochondrium, you should always suspect for left hemidiaphragmatic injury, injury to the stomach, injury to the splenic flexure or a transverse colon sometimes, injury to the spleen, injury to the pancreatic tail. After that, you need to assess carefully during your clinical examination also for the adjacent area, and then move away from the site of injury. But all the areas should be clearly assessed for, though you give more importance to the site of injury. With increasing gunshot injuries, remember that it is not necessary that damage is present only in a given area. It can also be distant and away from the site of injury if the exit wound is somewhere close to the opposite side. So the radiological assessment, which I generally explain it to my residents as a radiological assessment, should be done area specific, and also in a given area, you should go in a methodical manner, starting from abdominal wall, then the peritoneal cavity, then the retroperitoneal organ. In the abdominal wall, you should look for hematomas or the tract that is created by the penetration if there is a peritoneal breach. In the peritoneal cavity, we need to look for if there is any free fluid. It can be blood or enteric content. Using the Hounsfield units, we can assess comfortably if it is a blood or if it is an enteric content or if it is fluid. If there are any foreign bodies, especially if it is a gunshot injury in the form of bullet pellet, and if there is a hollow viscous injury, there can be abnormal enhancement patterns on the bowel wall. There can be intramural air. There can be pneumoperitoneum, mesenteric hematomas, and bowel wall thickening. Bowel wall thickening, though, is a non-specific finding, can still help sometimes in suspecting bowel injuries. Solid organs, especially liver, spleen, and pancreas, have to be looked for in terms of laceration, hematoma, and contusions, and their injury severity has to be graded for, and then look for any active contrast extravasation from the solid organ. These injuries have been detailedly discussed in the prior discussions. That is why I'm not going too deep into them. However, if there is a retroperitoneal injury, especially to the if the penetrating injury is too deep in anterior abdominal wounds, or if the wound injury is into the lateral aspect or the posterior aspect of the abdomen, then always carefully look for the paraduodenal areas, perinephric areas, and paracolic gutters, and solid organ injuries in terms of kidney and major vascular structures like IVC, aorta, and major intra-abdominal branches. We should always remember that for assessment of the vascular injuries, a biphasic CT is the bare minimum that is required in order to give better assessment of what is the point of injury. These are certain images which show the triple phase of the CT in a splenic injury. We can clearly see that there is a small contrast extravasation that is noted in the spleen following penetrating injury, and the blush is only increasing into the portal venous phase, and then it is further increasing into the venous phase. This is why sometimes there is a chance that we might be missing blush like this. That is why serial protocols in terms of arterial, portal, and the venous phases would help us in assessing that better. The same is true in the liver also. In this same image, you can see that we are not able to identify that there is an active extravasation in the liver in the initial arterial phase, but there is significant contrast extravasation that is noted in the liver in the venous phase. This is a penetrating injury, okay, causing, okay, this clinic laceration that is noted, okay, in this image. This is contrast excavation that is noted following, okay, the penetrating injury, okay, into the abdomen from the descending part of, okay, the colon. This is what I was explaining. Sometimes in gunshot injuries, the entry may be from one point, but the exit would be completely from the opposite side. In this case, the entry is from the right side of, okay, the abdomen, but the injury is noted, okay, on the opposite direction. That is, the kidney of the opposite side, okay, is affected. That is why we should be very careful, okay, in assessing, okay, gunshot injuries or high velocity firearm injuries carefully. Mesenteric injuries, especially when we see blood in the abdomen, hemoperitoneum, without an evidence of a solid organ injury, always suspect mesenteric injuries. It may not be as dramatic, okay, as this image that is seen. I've just kept it for understanding. There can be small mesenteric, okay, hematomas which can be easily missed. That is why they have to be carefully looked for, and only strong clinical suspicions can pick them up. In hemodynamically stable patients, we have only two options. Either we have to operate the patient or decide whether we have to do a selective non-operative, okay, management. The indications for emergency laparotomy are if there is an obvious peritonitis, evisceration, or impalement because of a penetrating, okay, metallic object, and if there is air under diaphragm or a GI bleed that is noted, okay, on the nasogastric, okay, tube following a penetrating injury, only then an emergency laparotomy is performed. Sometimes in hemodynamically stable patients, a CT may help us in guiding us the exploration. However, it is not mandatory to have a CT before, okay, emergency laparotomy, provided there is an indication for it. It can be an open approach or laparoscopic approach. The evidence for laparoscopic approach is gradually increasing. However, in PGI, we only still go by the conventional open approach. We should understand that laparotomy is still the gold standard. However, laparoscopy has the advantage of reducing the morbidity, and that has the decision has to be made only on the basis of the patient's overall status, availability of laparoscopy, surgeon's experience, and whatever might be the surgeon's experience in this situation. If the surgery is not proceeding, okay, on laparotomy, the threshold for laparotomy, if the surgery is not proceeding well or taking more time on laparoscopy, there should be a low threshold in order to convert it to laparotomy. Assessment should be done for the hollow viscous injuries, solid organs, and diaphragm. After that is performed, then the retroperitoneal assessment should be done. If there is a hematoma has to be explored in penetrating injuries. Definitive management, okay, is performed based upon the type of, okay, the injury. I am not going into the details of how solid organ injuries, okay, are managed. However, I will touch upon the bowel injuries, which are the second most common, okay, injuries following penetrating injuries in the abdomen. Small bowel being more common, okay, more common than large bowel, okay, injuries. Coming to the injuries that are possible, it can be a simple perforation or a transection or a gangrene or a mesenteric, okay, injury that is noted in the small bowel or the large bowel. And the options that are available are either do a simple repair, okay, of, okay, the perforation, do the resection of, okay, the unhealthy segment, and do the anastomosis, or perform a stoma. However, this decision completely depends upon the overall status of the patient and the status of the tissues, and what is the extent of associated, okay, injuries which have the possibility of making the patient unstable, okay, into the future. Most of the times, if the patient is hemodynamically stable and you are doing the emergency laparotomy as a part of definitive surgery, then primary repair of the small bowel should be preferred. Even if it is a colon, primary anastomosis of the colon is safe after a trauma. The risk of a leak only increases, okay, if in certain scenarios when the patient either presents to us as a delayed manner or certain factors, especially after the damage control of the surgery. If the time from the initial surgery is significantly high, that is more than 24 hours, or if the transfusions, okay, required are more than 6, if there is persistent inotropic support, if the tissue edema is significant and the intestinal edema is significant, maybe because of your resuscitation or persistent inflammation that is because of ongoing contamination, and what is the extent of contamination. These things decide if there is a risk of anastomotic leak is high. In such patients, probably you may err on doing the surgery more towards the stoma rather than the primary repair. So I'm showing certain photographs where a penetrating injury of the anterior abdominal wall causing through and through perforation, okay, into the stomach, including, okay, the posterior, okay, wall of the stomach. A simple perforation of the small bowel. here we can see the tractional venous injuries, okay, that are caused because of long-standing evisceration, okay, that has happened. We can significantly see the congestion, okay, on the eviscerated part of the bowel. There might be associated, okay, mesenteric injuries, okay, along with the perforations noted, okay, on the small bowel. There can be isolated mesenteric injuries with mesenteric hematoma and denudation of, okay, the segment of, okay, the bowel. This is a patient where a penetrating injury into the anterior abdominal wall, especially in the right iliac fossa, causing a cecal perforation, okay, is noted. Now, is it always necessary, okay, to perform an emergency laparotomy if the peritoneal breach is identified? Answer is definitely no. The reason is, in stable patients, very less number of patients would be needing operative, okay, management. Peritoneal breach in anterior abdominal wall injuries is noted only in up to half to two-thirds of the patients. Of these patients, only half patients would be needing an operative repair. That means the incidence of negative laparotomy would be significantly higher if we opt for a carte blanche approach in terms of doing an emergency laparotomy in all the patients with peritoneal breach, which can extend up to 24 to 57% as per the existing literature. In local wound examination, if there is no peritoneal breach, which is generally seen in 40% of the stable patients, they can be discharged. The remaining 60% of the patients have to be carefully assessed for underlying injuries. When do we consider the patients for non-operative management? Obviously, patients have to be hemodynamically stable. The patient should be in a status where we can get a reliable abdominal examination, especially if the patient is intoxicated or if there is a significant head injury where we may not be able to make appropriate clinical assessment in terms of abdominal examination. Then you may have to err more towards an emergency exploration rather than maintaining the patient on non-operative management, or reduce your threshold for operating such patients, okay, significantly. If there are no signs of all-viscous injury or vascular injury on your initial clinical assessment, and if the CT does not show any kind of significant operable injury, only then selective non-operative management is opted for. What do we do in it? We have to admit the patient, obviously, and keep a close monitoring of such patients, do serial clinical examinations, which include the vitals of the patient, focused clinical examinations, and regular hemogram alone is enough. Some people say even addition of lactate on regular basis is also useful. Examination, okay, preferably should be done by a single physician, and it should be carefully documented, especially in the form of a chart. And if it is given as an over, the over should be given only on the bedside by clearly showing what are the findings of the patient to the next physician. And most importantly, what should we look for? Look for the signs of peritonitis, fever, hypotension, or any SIRS that is developing during the non-operative management. It should be done at least for 24 hours. Evidence suggests that after 24 hours, the chance that we would be missing an underlying injury is significantly lower. The pooled risk of failure for non-operative management is around 7%, and the pooled mortality is around 0.4%, with anterior and flank injuries being, okay, more likely to have a failure during selective non-operative management. And what are we doing, preventing by not operating these patients? Obviously, significant morbidity that is associated with a negative laparotomy, wound-related complications, and long hospital stay, and the costs are reduced in terms of patients who do not need an emergency laparotomy. There are certain contraindications described, but I would not like to say them as contraindications. Only absolute contraindication is if there is an indication for laparotomy. Remaining contraindications described would be a relative contraindication. And in such a scenario, especially when we do not have the resources to serial clinical examinations, or when we do not have the feasibility to prepare an OT immediately within 1 hour, or an ICU bed within 1 hour if the patient deteriorates, such patients, okay, should not be managed in that given setup. Rather, a decision can be made in order to do an early referral to a place where it can be performed. There are various algorithms that are described in the anterior abdominal stab wound. If there is no evidence of shock, evisceration, peritonitis, or impalement, then there is no role of a laparotomy. Such patients can be evaluated with local wound examination and a FAST. If that is negative, such patients can be discharged. If the local wound examination or FAST are positive, such patients can be considered for serious clinical assessment in the form of vital signs, physical examination, and CBC every 8th hourly. If there is no new onset peritonitis or hemodynamic instability that is developed in such patients, there is no role for laparotomy again, and such patients can be comfortably discharged within 24 to 48 hours. Coming to thoracoabdominal region, this is an important area because it includes two cavities, chest and abdomen. And most of the times we have the dilemma in terms of whether we have to go with the chest first approach or the abdomen first approach, the thoracotomy or a laparotomy. That has to be decided based upon the location, the direction of the tract, and the extent of injury, as we have seen in the chest X-ray example. Sometimes the FAST and chest X-ray would be very useful in assessing if there is a hemothorax or a hemopericardium or a hemoperitoneum, and accordingly, you have to prioritize your management. Thoracoabdominal injuries, if they are stable, they have higher possibility to have occult injuries, especially the diaphragm. In such a scenario, a CT is very useful in assessing for the peritoneal like a breach with a good sensitivity and specificity. Thoracoabdominal injuries generally harbor underlying liver injury or spleen injuries or stomach or colon or hemidiaphragmatic injuries based upon whether it is a right-sided injury or a left-sided injury. Why are diaphragmatic injuries more common, more important? Because in thoracoabdominal injuries, diaphragmatic injuries are rather a rule rather than an exception. It is all the reason why we have to rule out diaphragmatic injuries. Even smaller injuries, because of the pressure gradient, it can progressively increase over a period of time, and the size of the defect once increases can present to you on a later date as a diaphragmatic hernia. This is more true, especially if it is a left-sided injury. That is why CT is performed in most of these patients. However, the problem with the CT is its sensitivity, which is reported in literature, is quite variable, like between 19 to 94% of the 19 to 94% was the sensitivity of the CT in diagnosing diaphragmatic injuries. It needs thin cuts, especially at least less than 7 mm of cuts, and multiplanar assessments have to be performed, which is not feasible in all the setups. We should look for specific signs on the CT, which can be a contiguous injury, especially to the liver, and the liver and the lung. Sorry, there can be a sir. Am I audible?
Yeah, you are audible.
Yes. Please carry on.
Okay, sorry. If there is a collar sign, especially if there is a diaphragmatic defect, and if we are seeing that there is a herniation of the abdominal content to the left diaphragm, that can be diagnosed easily. We can look for other signs like dependent viscera signs, where the viscera directly is resting on the posterior aspect of the ribs, which is seen when the diaphragm is not intact, or a dangling diaphragm sign, especially in case of larger defects of diaphragm is noted. In pellet injuries, we should carefully assess for the tract injuries to look if there is a possibility of diaphragmatic injury. Having said this, we should understand the specificity of the CT is very good, but sensitivity is quite poor. That is the place where we have to look for other options. Evidence says that diagnostic peritoneal lavage is useful, but it is not currently used because especially in the era of laparoscopy. A diagnostic laparoscopy rather is more useful in assessing what is the extent of diaphragmatic injury, and it could help in picking up 20 to 24% of additional diaphragmatic injuries over CT. And also, we have an additional advantage of direct visualization and repair of the defect in the same setting. Left-sided injuries definitely are more useful, are more helpful. LAP is more helpful, especially with left-sided diaphragmatic injuries, and it can be used either for screening, diagnostic, or therapeutic approaches. The caveat being, it is more invasive than non-operative management. It is more time-consuming, and with major splenic injuries and massive hemoperitoneum, there is reduced visibility, and it can cause the loss of basic purpose why a laparoscopy is performed, and we may miss diaphragmatic injuries.
Santhosh, you will have to finish.
Yes, sir, I'm finishing it, sir. And the last
I need
component
to
is
give 5 minutes to Dr. Monika for special comments and then Dr. Sastry.
yes, sir. In posterior and lateral injuries, predominantly they happen in gunshot wounds and stab wounds, and the risk of retroperitoneal injuries can increase. Especially the retroperitoneal muscular injuries and major vascular injuries are significantly high in patients with posterior and lateral regions. We should always look for kidney, duodenal, colonic, and even small bowel injuries. Retroperitoneal hematoma, unlike the blunt trauma, zone-specific decision-making is not present in penetrating injuries. All the zones, okay, if there is a retroperitoneal hematoma, they have to be explored for. This is because of the increased risk of penetrating injuries causing additional organ damage in zone 2 and zone 3 also. So this is one of the patients where we had a bullet injury to the back causing a duodenal perforation and IBC injury. Delayed presentations can happen especially with posterior stab wounds and when there are associated serious injuries or when there is delay in referrals. They have higher incidence of sepsis and higher increased morbidity, especially in terms of increased incidence of stoma requirement in such patients and higher risk of long-term ventral hernia risk because of temporary abdominal closure. These patients have higher incidences of prolonged ICU stays and hospital stays, and also need for intervention is higher in such patients. That is why a delay of more than 8 hours should be avoided, which causes significant worsening of the outcome.
Santhosh, I think you will have to conclude. You will have to.
Yes, sir. The take-home message is it is a lesser common injury, but it is increasing in incidence. Strict basics. We should stick to the basics, especially in assessment of trauma assessment. Life-saving procedures should always take priority in hemodynamic and stable patients. Damage control resuscitation has to be taken up. In hemodynamically stable patients, detailed assessment and clear roadmap using adjuncts of trauma should be performed, and we should decide between emergency surgery or a selective non-operative management. Do not miss the diaphragmatic injuries, especially in thoracoabdominal injuries. Thank you, sir. Sorry for taking some extra time.
So I will have to give a few minutes to Dr. Monika because she volunteered. Dr. Monika Gupta is one of the pioneer surgical gastroenterologists in the city of Jaipur, and she has a fairly large experience with management of trauma. Monika, can you please come in?
Sorry for taking some extra time.
So I will have to give Monika. Yeah. Monika, you are logged in with 2 devices.
Yes.
Yeah, please come in.
Yeah. My video is not getting on. It's okay. So Dr. Santhosh has covered a lot of issues in trauma. And I think trauma is like that. Everything, everywhere can be getting involved in various ways, maybe in a blunt way or a penetrating way or a sharp way. So I also wanted this type of coverage for a trauma webinar, and I think throughout the both of the days we have covered various issues. Only a few points, practical points I'd like to add, because the hospital where I work has been initially started as a trauma center by the government, and later on it has been a full-fledged corporate hospital. So there are few issues which are differently managed in a private setup, right? So that is the main message I want to convey. Particularly, more cases come to us with mesenteric trauma, although they probably they constitute only 10% of the trauma cases. In children, more are solid organ injuries, more than 50% are solid organ injuries. But for the surgical cases, more are mesenteric trauma. 90 to 95% of the liver injuries which we have encountered have been managed conservatively. And splenic injuries probably has been managed mostly conservatively. Only a few have been operated. In fact, a atraumatic splenic hematoma or a splenic bleed can also be present in some few medical variety of the cases where you need to differentiate from the traumatic splenic injury. Regarding the ER management of the trauma, various issues have been discussed, like this FAST and DPL and all those things. But I think CT stands the test of the time. In ER, first of the thing we have to do is to streamline the process of getting the imaging fast in stable or a patient who can be made stable, CT is required, and CT can be done very fast. Maybe in 30 minutes, we can get the CT films and imaging on our phones, even at the midnight hours. So that thing, every ER should streamline. What we do is, as the patient comes, our ER doctor does a VBG or ABG of the patient so that he gets a creatinine. And after getting the creatinine and stabilizing the patient in the meanwhile, if the patient is stable or already stable, then patient can be sent to CT. And obviously, as they have already said, that oral contrast needs to be avoided. Most of the times, we don't do any oral contrast CTs these days. If any case needed in elective setting, only negative contrast CT can be done. But positive oral contrast is nowadays, I think we skip it. Only IV contrast we advise after getting the creatinine. And if the creatinine is high, then we can get a consent sign or explain that there can be an renal issues, but CT is essential. So CT scan gives a lot of information about amount of hemoperitoneum, about the number of injuries, solid organ, as well as the pneumoperitoneum. Now here, if we have a stable patient and a sonography has been done, solid organs have been ruled out, there a plain CT scan can also be useful. A plain CT with a good radiologist reading down at their home screen or a hospital screen, but reading about the pneumoperitoneum. And finding very small specks of the air is also important. So at the midnight hour also, we keep one of the radiologists on call who reads these CTs on the phone. Although there is a rider that it may not be very accurate, and there is a rider then in the morning, some part of the reporting can change. But most of the times they are, I will say 90% times, they are very helpful, because in the early morning hours, we can operate those patients. In the midnight, we can operate those patients for the mesenteric as well as small bowel injuries. And it is very useful to do a plain CT also in the penetrating injury. Like we were discussing about the local wound exploration to find the peritoneal bleach, my approach will be doing a plain CT abdomen to find a small air speck in the peritoneum. So that air will guide me whether peritoneum has been breached or not. So if peritoneum has been breached, then penetrating wound can undergo laparoscopy or as well as open. And this is, I think I have started practically also, that in a very small injury where we are hardly suspecting any solid organ injury, but because of the medico-legal importance of the offering the surgery to penetrating wound, because it has been trend that if there is a penetrating wound, surgery should be offered. I don't know if we don't do any surgery and in any case later on patient turns out to have some gut injury, what will be the medico-legal significance, which should also be discussed in some later time or some sessions later. So in laparoscopy, we can find out whether there has been any blood or any other gut injuries. Gut can be explored in a milder form of penetrating wounds. And in case of major form of penetrating wounds, open surgery is desirable, because sometimes they can mislead us and sometimes we may think that no, there may not be. Recently, I have operated one young male where there was an 4 or 5 centimeter size of penetrating wound in abdomen. I was biased. Actually, I was biased and I was confused with whether to do go lap or open. But when I opened from the lower midline and the injury was on the stomach. Penetrating wound was on a left iliac fossa. So these can be the scenarios in the penetrating wounds. Gunshot, I think, is a totally different topic, and I think it can be discussed in one more separate session. And regarding the retroperitoneal hematoma, I get a bit worried about retroperitoneal hematoma when it comes with mesenteric trauma. Because retroperitoneal hematoma, when it gets opened or when we open it up, it can keep bleeding because the source can be pelvis, the source can be retroperitoneal structures. So either we need to confirm that the hematoma or a bleed has been stopped properly before we close the abdomen. Otherwise, post-op blood may be a problem in the post-op scenarios. And in case of trauma, one strange case I like to quote in the end. I don't know how people find it easy to get injured in similar way many times. So one patient we got in last 6 months, who was already operated for trauma, a big midline scar, who had got the stoma made, the stoma got reversed. And later on also with us also, he landed up with abdominal trauma, same. We made this trauma and we reversed this trauma. So these strange scenarios can be there. So definitely, sir, this session is very useful, and I hand it over to you for the further comments.
Thank you, Dr. Monika. I think we are nearing 9, so I would give last couple of minutes to Dr. Sastry. But Kishore also has said the same thing, that CT in a hemodynamically stable patient, even if there is an indication for laparotomy, is a useful adjunct, because it makes you better prepared. Dr. Sitaram has made some comments which are mainly what Dr. Sastry said, that for pancreatic injury, we are moving more and more towards a non-operative, and even if it is operative, more conservative management. Dr. Sastry, last few comments before we close.
I think we had quite a extensive discussion, particularly of penetrating injuries of the abdomen. Pancreas, I think we've already discussed, and there are changing trends, and how difficult it is sometimes to diagnose a pancreatic injury, and how imaging is the mainstay of investigation. Grading and the proper fallacies of grading, the newer gradings are also discussed, and the role of interventions, particularly in more severe injuries, grade 3 and grade 4 injuries. Grade 5 injuries, whatever you do is a bad situation. So a damage control situation is the only methods are the only recommendations, whereas in grade 3 and 4, where the ductal injuries are there, the right or left, and see how best we can conserve the pancreas and do enough drainage and debridement. If for left side resection, pancreatic resection, avoiding anastomosis. I think that would be the pancreatic take-home messages. Whereas in the penetrating injury, I think it is too extensively discussed. I think I only just wanted to add, as Dr. Monika was saying, laparoscopy in where peritoneum is breached in the penetrating injury, but the patient is absolutely stable and the abdomen doesn't show any clinical signs. I think definitely a laparoscopy would be quite useful. Also in thoracoabdominal injuries, where you want to see the diaphragmatic injuries, they are the ones which are generally missed, and they are best diagnosed with laparoscopy. I think that's about all. I'm sure we can go on and on. There are a lot of areas where we can have a difference of opinion, discussion, and evaluation of these things. And definitely things are evolving from the days when we thought, we were taught that a penetrating injury always requires surgery. Any penetrating injury, you must operate, to a guarded selection of patients for surgery in these injuries. I think with these comments, I hand over to Dr. Kapoor for the final, if any.
Yeah, we have a practice that we start at 7 and finish at 9. So we are already at 9:02. There are 2 questions from Dr. Vihar Kotecha, but Vihar is a regular attendee, so maybe we will take his questions in some other session. There is a note from Dr. Marcos Chahin from Dominican Republic, but he's just put his name. He hasn't put any question. I'll request Dr. Marcos to please send a WhatsApp message to Dr. Nagar so that we can add you to the online portal. So with that, I would like to thank TD. You want to make some comment quick? 1 minute.
Sir, I think it was very extensive topic, and Dr. Santhosh has to, because penetrating starts from chest, back, anterior, posterior, and all abdomen, anterior, posterior flanks, and I think lots of discussion has been done, and seniors, all of you have made already comments, so I don't think. Only thing I can one say that when we are doing a distal pancreatectomy and come to the right side of the SMV and portal vein, definitely we are finding diabetes. So it's not that we remove about so much of pancreas and there won't be diabetes. So one has to be very, very careful when one needs so much of pancreas to be sacrificed. So that is all I can say. Thank you, sir.
Okay, so I would like to thank all the speakers, Dr. Sastry as moderator and Dr. Sitaram for again being present. Thank you very much, everyone, and see you in the next masterclass next month. Thank you. Bye.
Thank you, sir. Good night,
Thank
sir.
you.
Thank you.